jump up and down,
Yeah.
run around the block.
4:50 in the morning radar. He got in on early on that one.
Yeah.
So, Saul, while we're waiting, give us an update on your podcast and
It's
the
going.
Northeast Regional.
Northeast Region Biofeedback Society. Yeah, no, it's doing good. It's we're doing a series on creativity.
Creativity,
So
okay.
Neurophysiology of creativity. Today I talked to a neurologist about compulsive writing.
Okay.
She experienced at some point. She had a manic break, but it's seen in bipolar disorder and temporal lobe epilepsy. So it's a temporal lobe, frontal lobe problem, and people just compelled to write.
You think with all these chat aids, I won't say AI, I'll just say chat aids, doesn't that help these people on the creativity or get them unstuck?
I didn't talk with this neurologist about it, but I talked to some of the other folks about AI, and most of them think there's a risk there that will replace creativity with whatever AI is, but that it seems to be able to play a supportive role. And I think that's probably in a lot of areas AI can play a good supportive role, but when we let it take the lead, that's when we run into trouble.
Yeah.
Oh.
Fair enough. Another endorsement for AI. Is that what you're saying, Saul?
Well, I mean, I use it, and I haven't used. I've only used ChatGPT primarily. Well, I primarily use ChatGPT, and I think it is useful for some things and useless for others. And it's not always easy to, So for things like, I may ask it to find references about a particular topic, and it makes them up.
Yeah.
So
hallucinations.
The hallucinations are an interesting problem. But then I may have it go through something I've written, and it does a great job.
Yeah. So. Well, it's a memory bottleneck and an execution bottleneck because nobody wants to let it execute. There are certain things that you can do, Claudebot and all that.
Yeah,
and
yeah.
I've starting to get into that because, again, we're waiting for somebody else to ask questions. So it's just you and I, Saul. We're shooting here.
We're chatting around, whatever.
So when I start a topic, I mean, that whole conversation, I got to save it in Notepad, date it and the topic, and then when I start again, I got to load that back up. And
yeah,
now supposedly with this Claude bot or whatever I'm using here to use Telegram to ask my questions, it'll save all the memory so it won't forget. And
yeah, ChatGPT is getting better at that as well, remembering things. So
well, that memory goes fast, right?
Yep. But I think it's good. There was a little bit of chatter online about using AI to analyze EEG.
Yeah.
Santiago Brand brought that up, and of course, because whenever he's done these things where he'll ask AI to analyze EEG, and of course, it just totally gets it wrong.
So, and I'm sure he goes back and tries to train it.
Oh yeah. Well, I think he's just trying to prove that it can't take his job. So.
Well, if the people that are using this and are not going in and saying what's wrong and fixing it, it's never going to get right.
No, you have to look at the EEG, and I think where it might be useful, and I think I got this from Jay actually. Is really good at pattern recognition, so it probably can do some of the looking for paroxysms, spikes and little seizure waves and things like that.
Yeah.
It could probably find that because there's enough out there for it to learn from. But for things like depression or anxiety and the stuff that we deal with, there just isn't enough data, and it's too variable. You have to really look at it and think about it in a nonlinear way, perhaps.
Well, I'll ask Joshua this because I think he's ahead of all of us on this. But using a general LLM, whatever it is, Grok, Gemini, insert here, I think there's specific services like if I want to get a video and I need help getting a face right, there's specific products that'll just concentrate on face. B-roll. Is there anything out there that's just concentrating on the EEG recordings, I wonder?
I don't think there is yet because I don't think there's a big enough market for it.
Yeah.
But, like anything else, it probably could be done. I mean, I think it could be, it can always do better than it's doing now. So,
less sucky.
I think Joshua would say our jobs are not at risk, at least not this week, maybe next, who knows?
Well, our jobs aren't at risk, but hopefully we can get more efficient where we can see more people with less effort.
Yeah. And I think, I think Joshua has a really good model for that. I think he's really working to figure out how to get this to more people more efficiently.
Well, he's all tied up with that oxygen.
Yeah. No, that's a great tool. It's a great
box.
Tool, not a toy. It's a tool. When we pay for it, it's a tool, right? When we're an adult, we get tools. No, but it's a terrific intervention. And I'm really glad that someone I actually know is using one.
Well, Radar kicked it off with what neurofeedback protocols do you think raise endorphins? So go ahead, burn up 60.
I don't really know. I mean, truly, I really couldn't answer that question, but I think there are probably easier ways to raise endorphins than neurofeedback. Exercise raises endorphins. So I don't know. I mean, maybe some excitatory training, but I'm always a little hesitant to do excitatory training because I think it's a little harder to deal with. I think people have a little harder time to deal with it than more inhibitory stuff or more balanced stuff. But Joshua's coming online now, so maybe he has a better answer than I do, which would not be hard. So.
Should we do a walk-up song for him?
Yeah, sure.
Joshua.
Hey, how's it going?
Oh, we're just kicking off with Radar. What neurofeedback protocols do you think raise endorphins?
Endorphins? Well, I mean, it's a good question. I would assume frontal lobe training would raise endorphins. That's just an assumption, though. I don't know.
I was thinking exercise.
Oh, of course. Training. I guess I'm thinking too narrow on what training is.
More efficient way. But I would imagine some like excitatory training, frontal excitatory training, something like that. But
we know exercise releases endorphins, though. That's for sure. Yeah. If you want endorphins now, go exercise.
It'd be faster.
A lot faster and a lot larger, like for sure. So I got CrossFit after this. Sorry.
There you go.
Speaking of CrossFit, how's the chamber working out? We were just talking.
It's going all right. I haven't found a lot of time to market it, which is okay. We like organic growth. So it's a little slow, but the staff are moving into doing some neurofeedback protocols. So I assume that financially things are going to balance out and get even here shortly. So it's a bit of a long-term investment. We're not aggressive marketers, and we kind of want in-house referrals. We kind of want people that we know. We don't want to be out there catching random people off the internet. So it seems like it's mostly appealing to people with a history of stroke. And they're friends of clients, relatives of clients, and all of them are reporting great gains so far, so they're all loving it. So that's fun. And I got the pre-QEGs, and so we'll do the post ones afterwards.
Oh, great.
Yeah. I have like 15 years worth of pre-post QEGs on HBOT. So I know what we're going to get. I just will have the be mine, and I have educational releases this time. So it's like, I got stuff I can actually show off. So that's gonna be fun. Yeah,
Josh, before Jay pops in, if he does, sure. I don't know what kind of day he's had, but Have you figured out the memory issue with using your AI, LLMs, whatever you want to call it, that it can remember your stuff from day to day? Like what do you do on that? The reason I'm bringing it up is Grok, Claude, insert name here. These generalists, they're all good for blocking and tackling, but when you want a specialist for, hey, generate me this face image or this B-roll image or this, there's specific products out there that handle specific things that do it very well versus the generalists do. And what I'm kind of wondering is, like, what are you doing with the memory side of things, and how could we have our own little crew here put together our own little special product, you know?
It can easily be done. It's just a matter of, you know, you can't have it distribute PDF files of research. And so that's why I haven't done it, is because you just can't go the step you want it to take legally, ethically, you know, where it distributes the actual PDFs. You can't do that. And so it takes all the fun out of it when you can't do that one step you want. It's like, oh, I've got, you know, 10,000 studies I can upload to this thing.
Like if I got an EDF file, it's a PDF, and I say, take out the identifying information, what else is in there that's ethically you can't do?
Well, you don't own the study, and so you can't actually put it on a platform for distribution. You can't do that. So I could put on 10,000 studies into an AI model, and it could answer questions, but I couldn't have it distribute the studies. And that's the problem, is I want it to be able to do that, and I can't. I'm not allowed to. It would be nice. I've done it for my own clinic. I just can't let everybody else have it. So
I guess what I'm saying, Saul and Josh, is if we got the recording before us and we take the snapshots and we say, hey, this is a wave, this is a, and go through the whole thing like that. Is there anything out there that somebody has done? Like, I know Jave's done half a million, but at least, but do we have somebody that's gone out there that said, okay, here's 20?
So what you're doing, you're wanting to have what's called an RAG or a GAR LLM model, which is basically a model that has partitioned known data sets that it references for instead of memory. And that doesn't hallucinate. That model doesn't hallucinate. It does have sort of semantic confusion, just like a real person does. It can confuse what theta is. If you give it slow alpha and you call it theta, it's going to be confused like that, just like a practitioner would be. Or if you have a lot of transients that you're using in Z-score, it might see that as theta content. It might call it theta. And so it's going to have some of the same semantic confusion, just like a person does. So we have that barrier to overcome. And that's where we have some really tricky checks and balances we have to program into it, which I have experimented with, and it's quite interesting. But the hallucinations are resolvable by just having the data sets that it trains on be referenceable to the actual LLM. But as I said, there's a problem with that, because the legality of using that for distribution is not there. So like, I can use that in-house for all the PDFs that I've acquired over the years, but I can't really let you have it. Does that make sense?
Got it. So Saul, you got a magic wand on this, or?
No, I totally agree with Josh. It's we can do more than we ought to.
Yes.
Legally and ethically. But that's always been true, right? I mean, that's technology for you. So
it's basically, I can use it to organize my stuff, but I can't use it for distribution.
Right.
So it's quite fascinating. You'd be shocked what I can do for my clinicians and my staff. I just can't let you have it. So you could always distill studies to condition tables. Yeah. So Ryan, is really good at creating these scraping AI agents that he'll build himself. I actually did one once, and it worked for a little while. But Ryan's actually good at making it work long term. He makes models that don't fail because some subscription runs out or something. Right. So I think I've made a few myself, but nothing that worked permanently. I'm missing some components. So looks like Anthony's in the lobby, I think.
Yeah.
Oh, Anthony.
There he is.
Hey, that was really neat discussion. I was overhearing I was listening to YouTube while I was getting ready about. Cool. Yeah, I didn't know that but does Gemini and AI, Google and ChatGPT, all those people, the big guys, are they able to? I mean, Google Gemini will show you the study, so they're able to do it, or what do we think?
without doing anything fancy, and you can absolutely do fancy things with like webhooks and things like that. But without doing anything fancy, you can generally upload like 20 documents, and that's technically on a little micro mini RAG model, where it's not going to hallucinate on the documents that you gave it, and it can handle, some pretty large documents, and it can handle like 20 of them generally. It'll limit you on a certain amount. Yeah, you can jailbreak it from that just by tying it into other programs, which will let you do. And again, Ryan, who's in the chat, he knows a lot more about that than me. I've done it a little bit, but only a little bit. And I've had some success with it. So you're sort of spending tokens, getting it to talk to other software to a limited capacity. And then you can get it to reference much, much, much larger databases. There are companies that specialize in doing that for you. So you can pay a subscription to kind of have the whole thing streamlined for you, which is fine. Let's see what they scraped.
Wait, so earlier it sounded like there's some kind of legal obstacle, but you're saying it's just a hurdle if they'd only let you upload so much data. Is that what I'm hearing?
No, both are true. Both so, for example, I like what I would want for myself and for my staff that I can't do is I can't train an LLM on referenced RAG-GAR databases. So it's got this string of like 10,000 documents, actually pulling the data from real PDFs.
Because those are subscription requirements. And probably you could point to publicly available studies, but you could not point to paywalled studies, I'm guessing.
I don't know. Yeah, we don't know where it's legal and where it's not. And what I would want is I'd want it to not only reference the studies and talk about the studies and do QEGs on the studies, but I'd want it to be able to let you to download the study from the actual chatbot. And you can absolutely have it do that, just not legally. So
it's not how you do it yet. The other thing is, well, anyway, you could feed it a bunch of neurofeedback studies, but you'd have a schizophrenic AI because nobody in this field agrees on anything.
Right.
So, well, that's a semantic confusion where the amount of prompting you'd have to do for a pretty smart agent to vet through, the types of checks and balances that we have semantically in our language, like when it says theta, how do you know that it doesn't mean slow alpha? How do you know that doesn't mean transients? How do you know that it means what types of theta? And then you've got studies mixed in that are like subcranial sensors. And then we're talking about theta that is not even remotely close to the stuff that you or I talk about. This is a totally different dimension. And so that's a dramatic semantic confusion. It's not different than the problems that you and I run into when we're reading these studies.
Exactly. That's the other thing. So there's no study that talks about SMR being what Jay refers to as SMR, other than Sturman or something. Right. When a neuroscientist says SMR, he means 10 to 13. He means high alpha, fast alpha. And he means mu. That specifically he means mu. And they'll literally use it. They don't mean what Jay means. And so there you go. The AI is not going to be able to understand that without a lot of prompting. And then
something can get confused. Yeah.
What is it? It'll get confused.
It's definitely going to get confused.
And then the other thing is, there's more. I just posted another study the other day that basically the more you talk to AI, the less accurate it gets. And so the first thing is, if you argue with it, what they found out is you're actually poisoning the well for future. The accuracy goes down when they test it. And then what is it?
It's the memory we talked about earlier. That's
you mentioned it. Yeah, memory's bad. And then the other thing they said is it starts to tell you what you want to hear. The more it knows about you. Yeah, you guys were talking about that. So, and it's not a simple thing of just purge the memory, because there's the other factor I mentioned. It's not just memory that's causing it to alter its because it was altering its responses. It was tailoring its responses to you before it had what they marketed as memory. So this is pretty deeply coded. I'm not saying don't use it, but I heard a phrase the other day that said, like, the more you outsource your thinking to it, the more risky. So I don't mind somebody using it to edit their work deliverables or something. Sure. But if you're like, how do I diagnose this client? Now I'm there's room for it, but there's a continuum there of better and worse.
Hear me reference? I don't know if I was having this conversation with you guys or not, but there's two studies that stood out to me. One was with high school students and one was with graduate students. And the high school students had found that the high school students were less sophisticated and had learned less and had grown less. Their brains were less developed because they used AI in high school. The graduate school students, however, it was the exact opposite.
They're better.
Well, so there's a difference in the way that you orient to the data. Are you using it to do less, or are you using it to do more?
Well, what's that Disraeli quote? Use statistics like a drunk uses a lamppost for holding them up rather than illumination.
There you go. Yes. Yeah. It's something like that. Yeah. It's exactly like that. Yeah. And so like there's a hygiene like element, like what is your orientation to this? Is this simply to reduce the strain on you, or does this give you the reason to push harder? And graduate students, I think they have enough of the world in front of them that they're going to use it to push harder. And high school students, they don't have the imagination for what they need to do next. And so they're mostly using it to cut corners. And then the neurological effect was very evident in studies, which is a big bummer. So, yeah.
And then, Anthony, you want to read El Chirardino's?
Well, he was saying, so he's saying, when I hear SMR, I think 13 to 15 over the central strip. Yes, that's what neurofeedback studies refer to it. But if you just look into SMR studies or something like that, that's not what they mean mu.
Yeah.
Yeah. I think that was, I don't know if that's still a current ongoing thing, but I know it used to be. It used to be.
I don't know who used it first, but I kind of went through this with Jay, like, but why are we the only ones? And he just kept saying, because Sturman. Graduate neuroscientists don't know who Sturman is, unfortunately. The average only somebody in neurofeedback world knows who Sturman is. So if you go around saying, because this has happened to me, and it happens to me all the time, if you talk about SMR in a neuroscience forum, they're gonna be like, I don't know why he's talking about motor activation or so. You know what I'm saying? Like, you're like, what is he talking about? So anyway, if you type in SMR sleep, okay, maybe now you're gonna get closer. Yeah, but that's not the bulk of studies when they mean SMR. So anyway.
Yeah. So
Radar says, why is 10 to 13 called SMR? Maybe we need to train 10 to 13 up at CZ.
No, that's there's when you read their studies, Radar, they'll also say mu, like they'll also say mu, but then they'll describe mu rhythm, which is suppression of the frontal lobe, basically, I think. So anyway, when you observe biological motion, that's what mu, or perform it. That's what mu rhythm is. I guess it's the central strip, actually. Yeah, it is. But anyway.
Yeah, it's usually C3, C4, although it could be
over
forward
C3,
or back.
Right.
Yeah.
And mu Radar 11 to 13 is not what's predominant in NREM sleep. That's the main.
Right. Yeah.
When I was talking to, I know 2 BCI researchers, and they were like, but why do you call it SMR? It's 10 to 13. And I'm like, no, that's not present in sleep. That's not what we're talking. That's not the sleep spindle. Oh, by the way, the most common academic term for the sleep spindle is sigma.
Right.
Or sleep spindle. That's what they're going to call it. They'll know what you mean when you say that.
Yeah. It's just when you're awake. That's what we call it SMR.
Yeah. There you go.
So I'm hearing you say that this is still a contentious point of conflict between different fields in neuroscience, and I know that it used to be. I didn't know it was still an issue. That's unfortunate.
Yeah. No, because you know why all of this is being studied for the BCI studies? Because they, like Neuralink, because they have to know about motor inhibition. Yeah. And mu is motor inhibition. So there's a million BCI studies talking about how they have to use SMR to suppress your motor or to activate whatever, and they're not talking about the sleep spindle. And so Chatterino had a question here. Isn't mu more CFZ? And no, I mean, Saul said it. My understanding is it's the allies C3, C4.
Yeah, C3, C4.
But it disconnects, as Jay says, what is he? I think he says disconnects the frontal lobe. Yeah. So that would be, I guess that might be where he's getting CFZ.
You'll see failure modes in the frontal lobe when there's excessive mu.
Yeah, they're correlated. That sounds, So alpha, beta, or theta will be commonly observed if you have 11 to 13 over C3, C4. Like.
And it has a wicket rhythm, so it's sharp on one side, round on the other, which is very different than sensory motor rhythm.
But this is why, so I was a little bit pumped to get on here, to be honest. And I was wondering if Jay, because Jay got on me a little bit on my wall this week. And he said, well, maybe I should address Radar's. Yeah, he says SMR can feel like it's disconnecting the frontal lobe. So maybe that's where the feeling is coming from. Maybe you're catching mu, and maybe the other guys can comment. And maybe it's having a paradoxical, some type of acute versus long-term reaction. What do you guys say to him on that? Radar on.
SMR can feel like it's.
Oh, could that be like the counterbalancing that we talk about?
It could be sedating. It can be.
Yeah.
So response to something, and it can be sedating.
Well, yeah. Although I think people usually talk about it as more jazzy.
Okay.
So, but
Yeah,
I
I
can see where
almost wonder if it's
disconnecting.
stimulating short term.
Yeah, because
Sure.
the counterbalance is inhibit only.
Yeah, for the frontal lobe, but you're inhibiting the failure modes of the frontal lobe. So you could do, mid beta training of the frontal lobe, but just overtrains too easy. We just don't do that.
But yes, this is why Jay got on me this week, because I posted a study about how Tourette's and OCD are correlated, and I can discuss all this with him too, but he's not going to mind, I think, but about what we discussed. And he said, stop diagnosing people, start using the EEG. And it's like, Jay, I don't know how to tell you this. Our studies are not good enough to get a doctor who's trained for 10 years to honestly tell him, no, you should just stop what you're doing. All your training, you need to throw it out. These studies you have with millions of people that show some benefit, I'm not going to say it's as good as our benefits. It's just not reasonable of us to say that to somebody, because you just saw us. We cannot even agree on what SMR and mute is. And you're telling somebody that they need to trust us more than people who are doing stuff that has much more data on it. I don't think that is intellectually honest. But the other thing I was going to say is, I feel like we're still the Wild West. I just had a friend, part of the reason why I'm animated. I had yet another friend that came back from doing neurofeedback in their town. They went to somebody. I'll be honest, when they go to people that Jay has not trained, it always ends up bad. Either they waste their money, or I had a guy go to somebody, his first session, he needed somebody to come and pick him up because he wasn't trusting himself to drive out of the parking lot. So I'm sorry, I'm less concerned about someone going to a psychiatrist than an average neurofeedback professional. I'm sorry, I am, and I wouldn't let. I'm getting really strong here because this is a lot of experiences. But,
I get the quality control concern. It is valid. I've looked around my town and I've seen what we have. It's a bit of concerning. It's a reason why I moved into teaching. It's like, okay, we got to do something about this control. Like, okay, we're working really hard to get insurance coverage. To what end? To a quality control nightmare. Because that's what happens next. That's literally the next stage. Because we're halfway there without it. And by the way, talk therapy is a quality control nightmare already, just so we're clear. Like, we'd be right there in the same basket. And for some reason they put up with it. I don't know if they'll put up with us, but they put up with it in talk therapy. If you think that talk therapy doesn't have the same problems, you're wrong.
Psychiatry in general.
Yeah. It's got very, very low efficacy for most practices, and there's very, very low quality control. And so we'd be right there with them, but we don't have to be. We could be better. We could actually be better.
We could, with the caveat that their data is still probably better. I'm sorry, a study with thousands of subjects. Our studies have 30 people in them, and it's just not. I can't talk to intellectually honest people and say to them that our data is as good as theirs. I just can't.
Well, I mean, it depends on what you mean by good. I mean, I don't see great gains in large studies in talk therapy. I just don't.
Well, I'm not, and remember, I'm comparing to pharmacotherapy right now.
Yeah.
Well, I guess maybe I wasn't clear enough.
Yeah.
And I thought
even that, it's not amazing. So, I mean,
it might be more predictable. And I'll just say from my experience, it's more predictable. And the studies are better. They're better.
Beating the placebo by 8%, I guess. Like, I mean, what are you cheering for?
Well, it's like half of people benefit from a lot of these medications. And
with a placebo that's 3 to 4 times stronger than the actual active effect. Like, oh well, I mean, great.
Okay, so then it's on us to prove that we're better, and I don't think we've done that. I don't.
No, you're absolutely right. You're right, and we don't have the money to.
Better. I'm just saying that.
We don't have the money.
The gains in these large studies are not phenomenal, is what I'm saying. Like, they have much larger studies, but they're not phenomenal.
Yeah, the problem with a large study, and it's a problem I wish we had, is that you can find a tiny effect because you have so many people, but is it a meaningful effect? And that's less clear with the large studies. That said, you're right. The basic neurofeedback study has 30 people with no control. So it's messy.
I feel like I know more what they'll get at a psychiatrist. There's variation, but so for every patient that Jay's lowering their alpha, there's some guy out there who's raising it in the exact. I'm sorry, it is. People are surprised to hear. I talk to people all day long on Reddit and Facebook. Like, my therapist is raising my alpha at CZ, And you know what else they'll even say? They'll say it feels great.
Sure.
So it's like I don't know what my friend
again.
is going to get if they go to an average neurofeedback. I have no clue. So anyway,
Anthony, you're fired up this week.
Yeah.
Yeah, I am. There were a few things. It's been a few.
Yeah, it's a problem quality control wise. And then you've got the proprietary systems that are black box that just most clinics use, and we couldn't tell you why it works. We can tell you what, evidence or standard they're using it on, what for. Maybe they've got a manual, maybe they don't, but it's just what they're doing, and that's common. That might be most of them.
Well, and so I will calm down and pause here enough, and I appreciated you guys' input, and it is moderating me to some degree. But so we have a question here from Lynn's brain, kind of interesting, maybe complex, but she says, I had at least 3 high-functioning autism patients, I assume, with very low delta, low alpha, and very low gamma, and everything else looks great. I don't know, maybe that sounds like Z-score. I tried all combos to raise, but the brains are just stuck.
Yeah, so it sounds like she's a practitioner.
Yeah.
Low delta, which is kind of common these days. Too much TV, not enough exercise.
Yeah.
Could be a good thing too. Low alpha, low gamma.
So are these low, like low fast EEGs?
Well, that's the question: is are we talking about low fast? Because the protocols on those need to be very, very specific, or are they just low alpha? And low amplitude cases are really tricky and frustrating, to be blunt, because we don't know why they're low power. It could be a trace mineral deficit, it could be a hormone deficit, it could be we don't even know all the things that can cause a low power map. But if it's not a low voltage fast, if it's just low voltage, I think Saul and I are picking up on the same thing. Those are frustrating cases because we don't know all the subcategories of what causes them and that they look all the same. It's probably the most frustrating phenotype you're going to run into. And there's studies showing that alpha theta training generally raises amplitude, but they don't really thank you for it. We watch their amplitude go up 30%, but they don't feel a lot better, and so I don't really do it often. I'm like, I'm not training their brain to look pretty. I need them to get, their complaint resolved, and I haven't seen the alpha theta do that in every case.
No. I mean, I guess one thing to think about, it's tough to know because these are tough cases. I know obviously we don't have the EEG, but I'd wonder about looking at the relative EEG.
Yeah, because maybe they have no neck and thick skulls or something.
Right.
Yeah, so you have to take into consideration the type of person in your chair. If they're a football player with no neck, then you do relative comparison because low amplitude would be normal. Maybe they're not low power. Maybe they're just, maybe they just have a thick skull. Yeah, that's a really good reminder.
That's what my wife says. Radar says, I agree that very thick skull. I agree that neurofeedback is somewhat uncharted territory, Anthony, and that's what makes it fun. It's the new frontier.
Fair enough. I like that attitude. That's an optimistic way of looking at it.
And then Lynn, welcome Lynn, of course. She's got it, at least. Go ahead, Anthony, read that one.
Well, this is the same one. She's still talking about the very low delta, low alpha. What I was going to ask you guys is, I think you might have mentioned already, is that something you're already looking into, thinking about like toxicities or something like that?
I would wonder about that.
Maybe, you expect to see more slowing and more theta content when there's toxicities, though. Maybe in the bad cases, you see beta spindles in the frontal lobe, that kind of thing. Bilateral shocks with transients increase, that kind of thing. So if you're looking at the raw data, you start to see some of those alarming factors that tend to present more as theta content. But skinny kids, I'd get a functional blood test. I'd want to look for have enough iron, do they have enough magnesium? Are they getting enough trace minerals? You want to make sure the blood work's good, because when you're low power, it could be something in the blood work, and there's too many things that can cause it. Then there's also just genetic reasons where the arteries in the back of the head are smaller than they should be, and so people just run low power, and they're just tricky on everything when you have those kinds of cases. And they can get diagnosed. I've had a few in my clinic get diagnosed with this, vascular disorder where the arteries are just smaller than you want them to be, and they're just low power and they just lower, and it's very annoying. And at that point, it's like, well, what increases peripheral vascularization? And there are a few things, but not a lot of things. Not a lot you can formally recommend, because safety issues. Hyperic oxygen therapy can increase peripheral vascularization. That's one of the few things I can recommend. But again, big expense, big time commitment. And what if it does the same thing as alpha theta? What if it improves the power, but doesn't improve the symptoms? It's like, leaves you feeling frustrated, which is a common outcome with these cases.
Gamma rides on delta too, so.
Well, cross coupling, you mean?
It's usually theta and alpha. That's usually what I remember.
Was it last podcast? I think Jay did say, no, it was theta and alpha. But I think the whole EEG is sort of nested in the SCPs, the slow cortical, and that's maybe a little bit in the delta. Maybe, I don't know. Maybe that's
delta, the 1 hertz to 0.10 hertz or something.
Sub delta, yeah.
Yeah, the neocortical potentials, as Jay calls them.
Let's see here.
You have to have silver chloride sensors to see that.
What type of sensor?
Silver chloride sensors. Centered silver chloride sensors can pick up the 0.10 hertz.
Very cool. Okay, with it's Chad. He says, well, some of the low power people wonder if it's natural. Are they more of a low torque system type? Somebody who's a car guy, maybe
low torque. So there is a study, I don't know if I can remember where it was, which bothers me, but I remember reading a study like 10 years ago that said that there was some association with engineers being more likely to be low power and not have symptoms from it. And so just because someone's a low power map doesn't mean that that's their chief complaint. It doesn't mean that phenotype is actually a problem for them, that there could be a different orientation. One theory was that their pyramidal cells are just oriented differently, and so their brain looks quieter. And so it's like, okay, maybe there's no mechanical problem here. And they're just a different type of brain. Like how many subphenotypes exist within the low power phenotype? And the answer is we don't know. We have no idea. They all look the same because they're all just low power. Right. Some of them can be perfectly normal with different pyramidal cells oriented differently. Some of them could be low blood volume since early development. Some of them could be a hormone issue, a trace mineral issue, or a hormone issue. You don't know. And so we don't even know. Like sometimes we find out, oh, it was an iron deficiency. They fix that. Boom, it looks way better. Right. Sometimes we find out it was a hormone, deficiency. They had a thyroid disorder. Boom, fix that. It's great. But you're not a doctor and you can't run all these blood tests generally. So that sucks.
Radar says, do you guys have any experience helping clients with a history of psychosis or who have been put on antipsychotics? This is relevant because a friend of mine recently had an episode and they're worried. And the other guys are going to have more. I actually have a friend who was on antipsychotics. And she went through Jay's sort of phenotype-inspired treatment. And Radar, you're not going to like it. A lot of what they did, and I know this didn't help you, but they suppressed their theta, and it got them off of Seroquel, which is an antipsychotic. By the way, this was administered by a psychiatrist. So anyway, so that's my story about that. You guys probably have dealt with much more.
There's a lot of cases, a lot of different types of brains, right?
Yeah. I mean, these are tough cases.
Yeah,
and there's not a lot of research evidence with psychosis or bipolar. There's some, but not a lot.
Well, there's a lot of different failure modes for the insula, so you can categorize some of them as being different various failure modes within the insula. And you'll get psychosis from the insula being interrupted with transients or beta spindles or too much alpha or too much theta. And so you really want to look closely at what's going on with the insulas because that can be really symptom predictive. But sometimes it's a persistent alpha eyes open map. I've seen psychosis and those be quite common. Now, that being said, you'll see plenty of persistent alpha eyes open cases and it won't be psychosis, but sometimes it will, and they'll look identical. And I don't really know why that is.
This pharmacotherapy question so if I sounded like I'm down on the technology of neurofeedback earlier, I want to say I'm not. And I had kind of an optimistic scenario that just came to me. There are studies more and more coming out about fMRI-based neurofeedback and other types, I guess. I don't know I think magnetoencephalography, I think they've even done one now. Okay. Yeah. And so that rankles us. Like we get upset because you don't need a giant expensive MRI machine to do it. But I'm wondering if something like this could happen, which is vagus nerve is being studied for mental health, seizures, everything. That traditionally has been an implant. But I think people are now making the intuitive leap. I can do the same thing with a non-invasive thing, a much cheaper stimulator that people can buy over the counter. And I think those studies, if they haven't been done, I'm feeling that shift. So maybe this little trickle of these fMRI neurofeedback studies, something, and Saul maybe knows a lot more, let's say, or Josh too. Maybe that can be, not that you or I can do something like this immediately or something, but maybe that leads a researcher to go, wait a minute, maybe it's not the fMRI aspect, it's the rewarding, and I can do a study and it's cheap, and anyway, so maybe good things may come out of that, is what I'm getting at.
Sure. Yeah.
Okay, and sorry if that was long-winded or I missed a question.
You're good. And
You know anybody in Toronto, Saul?
There we
go.
Isn't that where the Thompsons are?
Yeah, the ADD Center, Linda Thompson.
Yeah, ADD Center.
Yeah, that's one of the best clinics in the world.
Absolutely.
That's not Tiff Thompson, is it?
No, that's
Linda Thompson.
California. Linda Thompson.
Where is it?
Did people watch Jay's Talk It All? You guys may have already been familiar with it.
Linda's
got it. Linda's book.
Different Thompson.
Linda's book.
She's working on a new edition.
Oh my gosh! Another one.
It's going to be edited.
Dry.
It's going to be edited.
This woman's been working hard.
Remember the phone book?
Yeah, it's a phone book. Jeez.
It is. It's a great book.
The Neurofeedback book.
The Neurofeedback.
Michael Thompson.
Justifiably so.
My first mentor, tried to scare me away by having me read this before she agreed to mentor me. I had to set aside like 4 hours a week on Saturday and just go to like Starbucks and read this for 4 hours. Week. And that's how I got into the field. It was a bit rough.
And then Radar's got another comment there.
That was about my friend, and I mentioned that part of their treatment was they were suppressing fast and slow frontally at FC Radar 2, but it was more just to say, you and I had talked about theta before, but so that's kind of why but it's more to say that, I do think neurofeedback, I'm here because I think it has tons of potential to replace pharmacotherapy, and I'm very frustrated that we don't, because if it just feels like we should be able to show it, and then the people doing it, either they botch the methods, or the study's not sufficiently powered, or they force us to use DSM categories or whatever. So part of this too is frustration that we're not quite cresting, or we're not where we want to be yet.
Well, what's the bottleneck, Anthony? Let's think like AI. Like we have studies with 30 people. How many people do we need? I don't think we've ever got an answer.
There's studies with more than that, but I think pharmacotherapy, they're doing thousands a lot of times, not every time. But anyway, I really think, and it was Dr. Hill, I think, alerted me, when it's harder to patent the technology, they can patent a drug for 10 years. Right. And they look at the largest company in Norway is the Ozempic company, Novo Nordisk. Okay, so and that's because of patents. If they couldn't patent that, your mom would be making and already compounding pharmacies anyway. But you can do neurofeedback and you can make cheap hardware and all this. So the profit incentive,
not there. That's
part of it. And then there's academic hurdles. What do you guys say?
Oh, you're totally right. I totally agree. Yeah.
I thought it made so much sense.
It's you can't make money off of it. There's no infrastructure to do research. There's a lot of argument. Well, the blind controlled studies is not the best way to do it, but it's the world we live in.
Yeah.
So, and anybody can go out and buy equipment. Now, you can't you may not be able to get FDA certified equipment, but there's plenty of Neuroptimal is not FDA certified. Anybody can go buy it, and call themselves a neurofeedback practitioner, because it's not a regulated action.
That's interesting.
In Massachusetts and many other states, if I'm not a licensed psychologist, I cannot call myself a psychologist. So, but I can call myself a neurotherapist. Even if I don't have any training. So I think that's a lot of it. I also think because it's a fairly siloed. There are the different camps, and there aren't enough people to even have one camp, let alone the 7 that are out there. So I think that has a lot to do with it. And there's calls for trying to bring the field together, and I don't know if it'll happen. It would be nice if it did.
Well, and I have a silly little question, but I do kind of wonder why we are constantly compared to pharmacology. Like, why is that the standard by which we are automatically contrasted to? Because I feel like the mechanics behind what we do are better contrasted against physical or occupational therapy.
I think it makes a lot of sense. Something for me, Josh, is like if I want to feel different, I know I can feel different after I take a pill. I don't know that I'll feel different after psychotherapy or even physical therapy, you know, or I don't know that I'll feel better, but I know. And the other thing I was going to say is I don't want to say we're expensive, but
Sure we are.
drugs are
We're
cheap.
expensive.
Okay, thank you. Drugs are cheap, and I get it. We have labor. To do it properly. You guys put a lot of time in, but you know, they can go get an ADHD prescription, and it might actually work. I mean, I know people that it worked for, you know, at least for what they needed.
The labor behind it is a little bit more automated. It's a little bit more, you know, it's mass produced.
Yeah. Look, by the time that somebody comes in and I give them a QEEG, they'll have gone to a psychiatrist and walked out with an ADHD med and taken it. Right?
The barrier
you can go in 20 minutes and get the prescription.
Yeah.
So, and you're right, you will know if it works within 15, 20 minutes, whereas it could take weeks of doing neurofeedback training before you really notice in some meaningful way. So there is a lot of that. And you know, I think why we are compared to pharmacology is because it's the head stuff, right? It's the mental health.
Yeah. To me, it feels like a poor precedent personally, but you know.
Yeah, no, I agree with you, but I think that's, and we've sort of set
like
ourselves
the model
up.
doesn't match. Sorry, Saul.
Yeah, I agree. But I think we've also sort of set ourselves up for failure because we want to say we're as good as Adderall, we're as good as an SSRI. So we're already making these comparisons, which are not, we just have to lose in that level. But otherwise, you know, we're not taken seriously. If we want to be taken seriously as a health intervention, we have to play with the health interventions. We have to play in that world, and we're not really. I don't think we're great in that world, but we have to be. So,
well, I don't know how we could be great in that world because we don't have the incentive structure to be great.
Right, that's the problem. Totally.
Like maybe we've done almost, like if you. So I'll give an example. I went to the 2018 International Hyperbaric Oxygen Conference, you know, and they were way further behind on research than we are. And mostly because they're just talking about how unfair the comparisons are and how unfair the standards are. And they're not doing anything. And so we, by comparison, are way more accepting of reality. And we've rolled up our sleeves and we've done some great work. And so in some ways, it gave me a little bit of a renewed appreciation for the work that we have done, seeing that they've done some good studies, but not nearly as much as we've done. You know, and you know, they've got some fun stuff. Don't get me wrong. Obviously, I bought one for a reason. You can do some amazing pre-post stuff with like 40 days apart. You can show some great gains, but they just haven't figured out how to demonstrate that in moderate ways like we have. Obviously, we could be better because the amount of labor for every N is very, very high for every single one of those subjects. Very, very high. It's like an hour per session. So it's like 30 hours of work for one person. And you're saying we want to get hundreds in each study. And you're saying pharmacology does thousands. And so we got to get thousands. It's like, we don't have many.
It's not going to happen.
You know, there's an incentive system to create that. No one's going to invest the money. So, you know, there just isn't a mechanism for that to happen. So, but I would say that I feel like we've done pretty good considering what we have. So
no, I would agree with that. And it's just, how do you look at the evidence? I do believe that the public is looking at the evidence in a different way than healthcare providers. So we're getting more clients because more people are learning about us. And don't want to be on the medications. Now, whether or not they should be is a different question, but it certainly gets us people.
But isn't it you guys always get the worst case situation, last port of last call, you know, last chance?
Prefer it.
You see a lot of zebras, right? A lot of zebras, as they say.
I like that.
I actually was talking with a neurologist earlier today, and she said, you know, the only thing we've learned about neurofeedback is it's hooey. So because she was curious, because we were talking about, she was actually part of the podcast. And so, you know, we had this discussion about bio and neurofeedback, and she's going to start sending me people. So that's something worthwhile. One doc at a time.
Yeah, I'm talking to a famous trauma therapist. They come to our area, and I met with him and I was excited to tell him I was a neurofeedback provider. And he said, "Oh, I don't like any of that stuff." And my knee-jerk reaction is always, "That's okay. I like it enough for the both of us." And I kept doing this consult meeting with him, but within like 3 months, he was referring people to me. It's like, that confident, I don't like it changed for some reason after just, 2 months of meeting. Don't really know why.
You convinced him.
I like that.
Yeah. I think it was the attachment. Like, he had to know me. He had to see that I was committed to, quality practice, and that we were meeting over EMDR. We weren't meeting over anything. I never talked about neurofeedback. And then it was maybe more the conscientious concern over quality care that made him think, oh, maybe there's something to this neurofeedback thing, which the attachment he had with me maybe caused him to look at it again. And you're looking at it with fresh eyes, more willing to see reality because there's somebody that you're attached to. Maybe you stumble on different things. I don't know. That's my hunch.
Yeah. Personal relationship. Well, you guys are making me think of the reason I keep harping back on this thing of that neurofeedback is not just one thing. So there's a sentiment that I've encountered from even people that we've had on and stuff. Well, all neurofeedback works and it's all good. And like, I think probably to some degree that's true, but I think there's an extreme version of that I get too often. For instance, there was a person on this podcast and I like this person, but they told me personally, said, I've been doing this for 40 years, ISF or whatever it was, ILF. And I haven't even seen one side effect in 40. And I'm just like, and I encounter that. I almost want to say that's the predominant, but that's like half of therapists I meet. They don't even acknowledge it. And I don't, because that neurologist, there's a 50-50 shot in my book. Maybe he met someone other than Josh, and they're not as professional or and he gets a patient that comes back, either did nothing or I don't know, boss, but I couldn't sleep for 10 days or whatever the heck it is. And now he's soured on neurofeedback because we're not quality control. Quality control is almost like too light a word for it for me. It's like
I think you're right.
I agree. I shudder to think what percentage of clinics are practicing in a deficient manner. I don't know how to give that a quality, but like where it's like cringeworthy. And I shudder at what percentage it is because I know it's most of them. It's like, was it 80%? Is it 90%? Is it 95%? And it's like, I don't know.
Are we getting back to the licensing thing again, Josh?
Well, that doesn't matter. Even board certification, it's like, the standards are not that high. So
you don't have to do it. You don't have to do it.
Yeah, you don't have to do it. You don't have to do it. And here's the thing, your clients, they're not going to do it. They're not, unless the client sees multiple people and happens to stumble into somebody who's articulate and very, very skilled and practiced, they're not going to know the difference. They're not going to be able to tell the difference between them. And not everybody who's really, really, really talented in neurofeedback is going to also be articulate. And so that isn't going to orient every client to that which is better. And so, there's some interesting studies on this that Jay will cite sometimes where you need 5 years of experience using more evidence-based practices for it to actually show, in some moderate level of competency. Otherwise, it's just random what they're doing, just random. And there's some people that have more than 5 years of experience, but they haven't been engaging in the right circles and in the right academic practices, and they're still just doing random stuff. And that's what's getting Anthony all fired up, and rightfully so.
Appreciate it. Yeah. And then Radar had a question here. I've left him hanging, so I'll get one. Sure. Josh, he wanted you to know that he says that he's been seeing a lot of hyperbaric stuff, and maybe you can comment. And then he also asked, is alpha the only band that you can speed up or slow down with training? Which is interesting. Never thought about it.
I don't think so. No, I think I've seen beta waves slow down and speed up too. Yeah.
Maybe it's just the way we sort of think about alpha as the idling speed. So when we talk about slowing it down, and we're sort of thinking like tuning the engine down or tuning it up, whereas we can do that with the other ways, but we don't think about them in having the same function.
Yeah.
Have you been seeing hyperbaric alpha? Oh, what is that, Josh? Sorry.
It's a lot easier to train alpha. So doing more fine-tuned trainings like tuning it is a lot more accessible. Trying to fine-tune SMR, it's like, it's lucky if you can train it. Let's just say that. We're just grateful when we can train it. We don't get too picky about speeding up or slowing it down. But alpha has a phenomenal response rate to neurofeedback. So being picky enough to decide to speed up or slow it down, we do have that luxury with alpha.
Okay. Yeah. So Radar was saying, have you been seeing a lot of hyperbaric for mental health or otherwise? I feel like I've seen it, but maybe not mental health, but I could be wrong.
There is some good studies on good. I say good. They're small. They're very small. I wouldn't say that anything's great with hyperbarics. It's definitely not being pushed by science. They've not been great at doing studies. There are, I don't know, like 100 interesting studies. So there's not nothing, but neurofeedback has something like 6,000 peer-reviewed studies, and I'm sure some of them aren't great, but we have some big ones and we have some medium-sized ones, we have some small ones. It's a whole mix. But HBOT's a lot more limited, and none of them are huge, as far as I'm aware. But they have some studies with like 50 people who showed some evidence that it helped with PTSD. So they've got a few studies like that are small. They have a very, very hard time creating controls with HBOT for obvious reasons. HBOT is mostly propagating because it just gets fast results. And so it grows through word of mouth. That's just what happens. So,
and the results are in which area of your life, I guess?
Well, so if you're, depending on the protocol that you're doing, but if you
mental health
well, you know how we look at the brainwaves and we see vascular ischemia through like the slow edge of alpha, that kind of thing. You can take that off the board with HBOT. You can just have them do a sort of a burst of HBOT where they miss no more than 2 days in a row, and they do like 30 session dives, and you'll clear that off the board. That will no longer be a variable. And a lot of times you're getting side effects because of the slow edge of alpha. That's where you're getting your brain brightener gets prickly and side effects. Okay. If you get sick and tired of that roller coaster, you can just use the HBOT to remove that off the table. And if they still have any problems, which they may not, you use neurofeedback, and you can swing without pulling your punches, and neurofeedback can be used as hard as you want it to after the fact because they can tolerate it. And that's how I use it. So it's more of a complementary modality that sort of removes side effect prone individuals. It removes that off the table. Sometimes I'll use it in cases where I'm seeing a lot of neuromarkers that are consistent with inflammatory dynamics, and I'm almost afraid to train them. Right. I've got some really beautiful case studies that I'm allowed to share because I have educational releases of people who are just, 20, 30 microvolts of just delta and theta, just this towering monstering. And then they've got beta spindles all over the place, like large towering beta spindles that are larger than most people's alpha. And you clear that all out. And, that's potentially life-saving if you know what that is. You're like, geez, you can't leave that going for 10 years. That's not gonna do nothing, So to get that kind of off the board is a relief.
That's pretty cool. I'll remember that. I'll add this on my side effects file here. We have a question, and I'm going to try to interpret this. Eliana Kolev is asking, I don't know how to say that, but is there data on the type of content the bipolar spectrum person tends to write? I'm going to maybe choose to take this question as maybe what EEG pattern they have. If they're talking about what they write in their writings, I don't know.
I'm curious what the connotation of the question are.
Yeah, they're welcome to explain. I just remember Jay. I think he's saying beta is represented in bipolar pages in his knowledge.
Yes, specifically greater right than left. And so think about it in terms of the right hemisphere is like emotional regulation, and you have an excitatory imbalance in the right hemisphere. I actually just published a class on this, so it's online. So you have this excitatory emotional regulation state of the brain. So it's in a failure mode and it's overexcitable. And so that kind of explains the symptoms of like bipolar. You get the mania. And then you have a lack of, a lack of the kind of logical part of your brain. Basically, it's not as well balanced. You have this sort of large impulse excitability and then low logic regulation. And that's kind of what forms the mania dynamic. So you would suspect if you saw beta spindles greater right than left, you'd want to rule out bipolar. It's not the only person that gets bipolar, though. So it's not that every person with these beta spindles greater right than left is going to be bipolar, and not every bipolar patient is going to be beta spindles greater right than left. It just triggers a rule out. That's all. And more than half of them are going to say yes, they've had hypomania or mania.
Okay.
Radar says, Anthony, I suspect what's happening is that people who get bad results just appear, and so they don't even hear their complaints.
That might be
They go into the Facebook. What's that Facebook
Yeah.
group?
Yeah.
Yeah.
The one not allowed into anymore.
Neurofeedback ruined my life, or whatever.
Yeah.
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 But you know, I have sympathy. I think there's some real cases in there, and
Sure. Though I have met with those individuals, and their stories are quite complicated.
Yeah.
I won't go into personal details, but it's not that simple.
It's often not that simple.
Yeah.
There's some people for whom that it feels like the neurofeedback was the issue, I will say. And there's others, you know, you'll get a lot of rigidity and they'll say, yeah, I don't know why the neurofeedback's not working. Also, I'm microdosing every day.
Right.
Or I'm on benzodiazepines for the last 3 years.
Exactly. It's like, would you consider, like I'm saying it, I'm not exaggerating. I was like, okay, had you thought about maybe just for the sake of the experiment, while, you know, whoever is treating you, that you stop the, oh no, I don't stop that. And it's like,
right.
Okay. So, but yes, I think there's a couple case, there's many types. Go on.
Yeah. At least tell your provider you're doing it.
Yeah. That would be good.
It's like you find out, you know, 6 weeks after you started training that they're microdosing or smoking cannabis, and
oh no.
Yeah.
Like, but that's normal. I mean, that's normal, right?
Yeah. We generally do okay, but you'd wish you knew everything in the beginning. Sometimes cannabis is a little easier to catch because I feel like some of us can actually identify it in the EEG, and we're like, are you telling me everything in the intake paperwork? You know.
Exactly.
I had some pretty comedic cases. I can't go into all the details on all of them, but there was some comedic case where I've got you know, I'm like, you had a party night last night, and they're like, oh man, you can tell. I'm like, yeah, and then later, you know, they were wanting to use me in court, and I was like, you don't want to use me in court, and they're like, why? I'm like, because you don't want my paperwork in court, and they're like, oh, you know, it was like, you know, it was one of those.
That was a good way to handle it too, by the way.
Yeah, it was. That's great.
You can pull me in, but I don't think you should.
But I have something Radar's getting, and I think is well, maybe he's not. He's saying maybe these providers that are telling me that side effects don't exist because I've met them. Maybe they're just not hearing about it. And I think there might be something. There's a phenotype, I would call it, or a personality type, let's say. I think that maybe because neurofeedback is a new field, somewhat new, and it takes some courage, it takes confidence. There is a type I meet that is what I would maybe call like an overconfident type. And so they hear, oh yeah, I'm exaggerating, but bipolar, we can take care of that. And ADHD, no problem. And everybody knows this is the only way to you. And I use, you know, Jansons, I'm making up a name, and everybody knows that's the best. And that is not helping us, in my opinion. And the problem though is I think that is to some people, that is an attractive, like those people seem to have success marketing themselves.
It's the
whereas
only
I feel like careful approach sometimes doesn't market as well. What's up, Josh?
So I think it's like our own nature conditions that to be the only personality on the top of sales. Yeah. And there's nothing we can do about it. There's literally nothing we can do about it.
So look for the financially unsuccessful practices, and those would be the better practitioners. Is that what you're suggesting?
So here's the thing. I wouldn't say successfully. I think there's probably a formula that isn't going to be that simple, but there is a formula like look for the one who never markets, who's still well off, that doesn't make large promises. Like look for the person who shouldn't be in business but is. You know what I mean? Like look for like that Mexican food place that's like in a hole in the wall, and it's been open for 15 years. And if the food wasn't absolutely fire, they'd have gone out of business like 12 years ago. But they're still in business, so the food has to be fire.
That was amazing.
You know, that logic. You know, maybe there's something like that, Saul.
No, and I think you're right. And it's what do we promise?
Yeah,
and what do we not promise? More importantly, so
there's have you guys ever heard of the guy Tim Ferriss? He's okay. He's kind of business / self-improvement, big podcaster guy. Anyway, he has a thing on he wrote a book on physical fitness and stuff, and he said, don't look at the Michael Phelpses of the world with the special examples or the special advantages. Look at the Muggsy Bogues of the world, like the short guy that still plays in the NBA. Look at the guy who doesn't have the swimmer's body, who kills it because he's learned like a hack. I'm exaggerating, but so I feel like that's a little what Josh is getting at.
That the Michael Phelps could have been doing, you know?
Yeah.
Yeah.
So anyway, that was cool. Cool metaphor with the restaurant too. I liked it.
All right, let's sell some tickets, ladies and gentlemen. Saul, what's going on in the Northeast, my friend?
Oh, same. We're finally getting through the snow, I think. But no, working on I still have my podcast with the Northeast Region Biofeedback Society.
Cool.
That's Healthy Brain, Happy Body.
Mm-hmm.
That's what's happening. We're starting to get ready. I'm also involved with Association for Applied Psychophysiology and Biofeedback, AAPB. We are getting ready for our conference in May. So that'll be fun as well. And that's what's going on up here.
Radar's saying, hey, we're going to interview Dr. Hill for his new book. If he's got free time, Radar, I'm with it. I'm with it, baby.
Radar, I'd be curious to drop us a line what it's on or what you've heard. You can reach us, you can do it here or later on Facebook or something if you want.
And then Radar, reach out to the side too. Let's get you on this side of the glass just for giggles.
That'd be fun.
Why not? Why not?
Yeah.
Joshua, let's move the needle on that chamber.
Sure. So yeah, I gotta start, doing something to market that better, but it's still advancing and growing, and that's going fine. And the technicians that are monitoring it are starting to do a little bit of neurofeedback, so that's good. I did manage to finish the frontal lobe asymmetries class. I haven't formally announced that it's out there online, but it is. So there's a little bit of a sneak preview for people who want to go check it out. You can get it at a discount at qegcourses.com. So I think we're done with 4 modules right now, where our goal is to get to like a dozen, cover all the phenotypes, etc. I'm going to add an hour of, I did some WinEG classes on there, but I'm going to add another hour of WinEG to it. And then by the end of this weekend, I'll sort of start putting it out on the internet. But you guys can access it early if you'd like. So it's like a pre-announcement to this group. So qegcourses.com does have a new module. If you've already subscribed, look to your email because there'll be like a discount that's the better discount for early members. So
You like better. Speaking of better, Anthony, you know any better chats out there that I can't get banned from?
Yeah, right. Yeah, the several Facebook, any neurofeedback Facebook group we're all probably a member of and active in. I was gonna say I think some people we know are active on Dr. Hill's Discord. He has a Discord chat. It's like a chat server. So you may find some interesting and I think he advises he's active on there. So there's cool stuff like that. So yeah.
That's where all the AI knowledge comes from.
Oh really? from Discord?
Be a part of the knowledge.
Yeah, there we go.
Joshua, Saul, Anthony, Radar. Going down. Elian. What else do we have? We had Lynn, Chad.
There's a new Brain something person, or is it Lynn Brain or Brain Lynn?
Lynn Brain, she's been around.
Lynn's Brain. There we go. Sorry, Lynn. Yeah,
Lynn,
thank you.
We love you, Lynn.
El Chatterino, don't be going in and there are all the hidden sauces kept there. Yeah. I would say El Chatterino, he's on Discord. Whenever I connected him, he always uses Discord.
And then like Radar did, he popped in at 4 a.m. and asked a question, and he was the first one in there. So, cutting in line. I love it.
That's nice. Thanks, Radar.
All right, everybody. Have a great evening. See you next Wednesday, 6 p.m. Central, 4 p.m. Pacific, and of course, 7 o'clock on the East Coast. Everybody, have a great evening.
Thanks,
all right. Appreciate it, guys.
Bye.
Bye. Bye.